咧係一個嗱咁，但係首先第一個 case 我帶出嚟咧就唔係一個 guided surgery。我哋講翻 before 我哋做 guide 之前，我哋點樣 handle 一個植牙嘅手術咧？喺以前咧，我哋若果要做植牙嘅時間，呢個 case 呢個病人嚟到佢係一個30歲嘅女士，咁就唔好彩，因為一個意外咧，令到咧嗰個門牙咧就受傷，咁就斷咗。咁我哋咧就需要幫佢重建翻啦。作為一個牙科醫生，咁我哋亦都因為本身病人啦，佢自己嘅真牙係健康啦，我哋唔想傷害到真牙啦，咁所以我哋咧盡量都希望咧用種牙嘅方法咧去幫佢重建翻佢嘅笑容。好啦，種牙就擺咗落去啦。我哋睇唔到嘅係種牙，病人或者係我哋做完個 case 之後咧，只會見到佢嘅笑容，見到佢嘅牙齒嘅啫。但係承載住呢一隻牙套嘅係一支喺牙床入邊嘅 implant。當作為一個 implant dentist， 我哋要擺呢個 implant 落去呢個病人口裏邊嘅時候，我哋要設想啦，呢個 case 我哋應該點樣做呢？其實咧，我哋咧心底裏邊咧係已經係有晒好多嘅 dimension 出現咗，包括我哋要將呢個 case 呢支 implant 擠落邊一個位置，令到嗰個 implant 同埋啲真牙有一個適當嘅間距咧。如果個間距拿捏得唔好嘅時間，會唔會有機會導致一啲後遺症，例如可能增加咗個牙骨嘅收縮，又或者係令到嗰個牙骨收縮，導致有個牙肉嘅萎縮咧，可能 lost 咗個 papilla 啦。咁呢個係 mesial distal 嘅考慮啦。咁當我哋若果係擺 implant 嘅時候， vertically 應該擺幾深咧？亦都係另一個我哋要諗嘅地方。我哋好多時 implant 到底係咪越深越好？又或者淺得滯又會有啲咩問題？到底嗰支 implant 若果係由個 implant 嗰度長個牙冠出嚟嘅時候，嗰個模樣係點？其實背後我哋有一連串嘅考慮。好啦，喺呢個 2D 嘅measurement 裏邊，其實係背後係承載住我哋一個 3D 嘅結構。係啦，一個 2D 嘅 dimension 上面嘅考慮嘅時候咧，其實咧我哋背後咧亦都係嘗試去咧建立一個 3D 嘅 architecture。點解咁講咧？因為咧我哋個 implant 擠咗落口裏邊嘅時候咧，其實咧係要由個 implant 嗰度長個牙冠出嚟，中間嗰個。佢哋唔好聽到，不如你揸住。哦，好啊，好啊。OK。好啊，好啊，好啊。OK。對 ，OK， 好。咁咧就非常好啊。OK， 好。咁咧就我哋做種牙嘅時間，我哋 plan 一個種牙嘅時候，我哋除咗有 2D 嘅 dimension 我哋要考慮之外咧，其實咧亦都係 based on 呢個 2D 嘅 measurement 咧，我哋係要設計成個 3D 嘅 architecture 出嚟嘅。我哋個 implant 點樣長出嚟，令到我哋做出嚟嗰個 implant crown 係可以自然呢？今時今日咧，我哋咧做 implant 咧，唔單止係講緊好似以前咁 ，OK， 做完出嚟之後咧係會食到嘢㗎，佢好襟用㗎。我哋仲希望咧係做到一個仿新嘅效果，即係換句説話講係病人睇落去，甚至乎係我哋自己牙科醫生睇落去，都係覺得係同真牙咧係好接近嘅。咁呢個結構係點樣樣？係由個 implant 嗰度承載出嚟，其實就好透過我哋點樣去 design 嗰個 3D 嘅 emergence profile。咁所以成件事其實係一個 3D 嘅設計，同埋 within 呢個 3D 設計裏邊咧，我哋未必有好多個走盞位嘅啫。好啦，若果我哋再 start from scratch， 由頭做多次一個 case， on Monday morning 個 patient 行入嚟嘅時候就係咁嘅模樣。咁我哋點樣去重新去設計過呢個 case， 再放呢個 implant 落去呢？我哋頭先有 go through 過嘅就係呢支 implant， 我哋需要用一個咩嘅我哋需要考慮一啲咩 dimension 去令到我哋可以將支 implant 擠落去，係可以做得翻呢個仿新嘅牙套出嚟。 咁呢一個 concept 咧，其實咧就同 Stephen Covey 講嘅 Seven Habits of Highly Effective People 嘅 Step 2 Habit 2 Begin with the end in mind 一樣啦。我哋咧喺設計呢個種牙之前咧，其實已經要有 final 嗰個牙套嗰個模樣噶啦。咁當然啦，喺未有 guided surgery 嘅時間咧，我哋係用咩方法做呢？我哋係需要用一個 victim form 嘅 guide 話俾我哋聽。手術當刻已經要考慮到底嗰個將來個牙套個樣係點，跟住 base on 呢一個將來牙套嘅模樣去放我哋個 implant。咁呢個係我哋以前未有 guided surgery 嘅時候嘅一個做法嚟嘅。好啦，咁若果你話我唔咁樣做嘅時候，當然我哋擠個 implant， 我哋希望個 implant 擺喺骨裏邊啦。但係如果我哋擠咗呢一個guide，呢個 victim form guide 落口之後呢，就會明白呢，如果我哋真係要將個 implant position 係一個適當嘅位置，同埋係要做到一個例如一個 screw retain 嘅效果嘅話呢，呢個 implant 呢係無可避免地呢一定會有 bone perforation。咁所以呢，喺guided surgery 嘅 concept 裏邊呢，正正就係呢個 guide 呢提醒緊 clinician 到底我哋點樣去做呢個 surgery。令到我哋可以做到個 final 嘅 outcome 係 as 我哋嗰個設計嘅。咁咧就喺implant position 上面咧，其實咧我哋基本上已經係好多嘅 paper 出過 ，Professor Stephen Chan、Professor Daniel Buser 有好多個 paper 講關於 ideal 嘅 3D implant 嘅 positioning。咁佢哋就提過話，我哋將個 implant 咧要擺喺一個好 narrow 嘅 safety zone。離開個 safety zone 去到 danger zone 嘅時候咧，就會有好多唔同嘅 consequence， 包括我哋頭先所講嘅 3D 嘅 dimension 啦，亦都會考慮到就係嗰支 implant 嘅 tilting。如果我哋個 implant 係挑得唔啱嘅話，會唔會令到嗰個牙冠裝完之後會容易有呢啲 recession 嘅問題啊，或者係做唔到 screw retention 嘅效果咧等等。咁更甚或乎咧，就係咧今時今日其實咧，我哋咧已經知道咧 implant 係一個好 success、好成功嘅一個 treatment modalities。咁點樣可以由呢個 3D 嘅設計延伸到一個 4D 嘅設計咧？講緊嘅係我哋今時今日做 implant， 我哋 expect 嗰支 implant 唔單止係要 last 10年啦，10年已經係太短嘅時間啦。點樣可以令到支 implant 20年、30年都係 stable 咧？咁呢個係 throughout time 咧，我哋個 dimension 都要好 stable。其實咧就係好靠我哋擺 implant 嗰刻嗰個 3D positioning。好啦，咁講完以前我哋冇 surgical guide 嗰個年代點樣去 handle 我哋嘅 implant case 之後咧，跟住落嚟咧就會講分享4個 case 啦。關於好啦，我哋 surgical guide 嘅年代做 guided surgery 嘅時間，點樣可以咧令到我哋啲 case 咧係做得更加好。咁呢個病人入到嚟嘅時間，亦都係今次唔同。今次呢位咧係位60歲嘅男士，咁但係咧60歲嘅男士都可以咧對外貌咧有要求嘅。咁佢嘅 case 咧嚟到嘅時間咧就都係一個 2-1咧，有一個 apical collision 嗰個 endo 咧就 fail 咗。咁喺討論過之後咧，都決定唔再做 re-endo 啦，我哋咧就選擇做種牙啦。透過做 guided surgery 嘅方法，我哋可以咧將個 implant 嘅 position 咧可以好 reassuring 咁樣擺到落去我哋本身原先設計好嘅位置。咁喺呢一個 surgical guide 裏邊咧，我哋除咗係個 guide in place 之外咧 ，implant in place 之外咧，我仲放咗一支 impression screw 去嘗試去 show 俾大家睇咧，嗰個 implant 嘅 position 咧同個 guide 咧基本上咧係可以好 follow 住我哋 guide 設計嗰個位置去擺個 implant。咁同埋咧，因為我哋有咗 guided surgery， 而如果我哋係可以係好 proper 咁樣去 execute 個 surgery 嘅時間咧，我哋可以將呢個 case 咧係用一個 immediate implant 嘅模式去 carry 去做出嚟。咁當然啦，今時今日嘅病人嘅要求咧就係咧，我哋點樣可以做個 surgery， 裝個種牙，同時間仲要係 same day 咧，我哋有隻臨時嘅牙套。And then 病人入嚟之前有隻牙，出翻診所之後仍然係有隻牙。我哋點樣可以做到呢一樣嘢？我哋要好需要將我哋個手術咧係好 flawless， 或者將個 error 減到最低嘅情況之下咧 execute 出嚟。咁所以最後呢個 case 咧，我哋就裝咗個 即時嘅臨時牙俾佢啦。咁同埋咧就係成個過程咧，我哋係唔需要咧去亂針嘅。咁病人當然會好滿意啦。咁到最後啦，佢個 case 做完咗之後咧，除咗個 implant crown 之外咧，咁當然另一隻牙啦，我哋都需要換埋佢。我哋希望可以做到嘅，正正就係呢一個好仿新嘅效果。我哋希望做完之後，病人睇翻，其實佢哋會覺得佢而家個模樣先至係佢自己真正棚牙嘅模樣，係啦。牙套其實已經唔同牙唔啱顏色嘅牙套，其實已經係上一代嘅設計嚟㗎啦。咁但當然啦，除咗呢件事，除咗係要靠一間好好嘅 lab 去做一個好仿新嘅牙套之外呢，其實背後承載住呢一隻 implant crown 呢，就係我哋支 implant 嘅 positioning。咁點樣可以做得到呢？就係靠我哋 guided surgery 嗰個surgical execution。好啦，咁講完 anterior implant 或者個 immediate implant，咁好多時呢講到 guided surgery 呢，好多時都有人問。到底係咪真係個個 case， 或者係咪真係好多 case 適合用呢？其實 day in day out 我哋好多 implant surgery 嘅 case 呢，都係做 single implant， 做 posterior implant。咁到底呢一啲 case 又適唔適合，又或者需唔需要做 guided surgery？ 甚至乎有啲人話點解你 single posterior 嘅牙齒都要做 guided surgery 呢？咁我哋睇睇一個 posterior 嘅 case。咁首先第一樣嘢想問一問大家。有冇覺得呢一隻 posterior implant crown 有冇啲咩問題呢？咁我哋做咗一個 implant crown 喺度啦，即係4-6。咁你4-6有啲咩嘢問題呢？Too lingual， 大師一次中的，真係講中晒。咁就好多時呢，其實呢，如果我哋做一個 posterior implant crown， 其實講到尾都係希望想做一個 implant 一個 screw support 嘅 screw retain 嘅 crown， 咁冇問題啦。我哋將個 screw channel 擺到喺 occlusal 嘅話，基本上就已經係做到一個 screw retain 嘅 crown 啦。咁但係其實如果大家有細心留意嘅話咧，呢一隻 crown 嗰個cervical margin 咧係太過 apical， 最主要嘅原因就係正正就係因為 too lingual 個 position。咁呢一樣嘢咧，其實咧間唔時都會發生嘅，尤其是我哋 freehand surgery 嘅時候咧。我哋一揭起咗個 flap， 開始做我哋嘅 implant， 我哋梗係希望將支 implant 擠落去骨入邊，多多少少咧，我哋會希望咧好 safely、好安全咁將個 implant drill 擠喺 within bone。咁 at the end 咧，好多時我哋會發覺，哇 posterior 我哋打支 implant 都唔會好大支嘅啫，係咪？一隻 molar 可能佢個 tooth width 有7-8個 mm。個 ridge resolve 咗都有6個 mm， 我打支4 mm 嘅 implant 落去就唔使 GPL 啦。咁但係其實咧，我哋咧其實係 violate 咗我哋個 implant positioning。當大家見到呢隻牙個 implant crown 係 too lingual 嘅時候，大家見唔到嘅位置就係呢隻牙喺 buccal side， 其實就會有一個 buccal 嘅 overhang 喺度。長遠病人喺 cleaning 方面咧，其實咧就會遇到有問題。嗰個位置 keep 住可能都會特別容易會邋遢啦，同埋會發炎。呢一支 implant 個 positioning 咧，就我哋將佢搬翻個 buccal 少少，你會見到個 difference。或者我哋將兩張相擺埋一齊嘅時候咧，你就會睇得到個 difference。點解我哋會話有一支 implant 左手邊有支 implant 個 position 比較正確啲，右手邊有支 implant 咧嗰個位置咧就太過 lingual 咧，個效果就喺度。咁點樣可以 execute 到個 surgery 咧？都係靠 guided surgery。Even 我哋做一個 single implant crown 咧，其實咧都可以用 guided surgery 嘅方法咧，令到我哋原先 plan 嘅手術咧，可以咧真真正正喺病人口裏邊做到出嚟。咁如果大家有做過 posterior implant 嘅時候咧，尤其是 freehand 做嘅時候咧，你可能都會留意到病人咧擘唔大個口。咁擘唔大個口嘅時間，我哋只能夠盡量叫病人擘啦。盡量叫病人擘嘅時間，支 handpiece 如果頂住 opposing 嘅牙嘅時候，只會得出一個後果，就係嗰支 implant drill 會 drift 啦。但係如果我哋用咗 guide 嘅時間，起碼 at least 我哋會知道嗰支 implant 咧，其實咧係嗰個 implant drill 個 entry 咧，其實係離開咗我哋想佢擺落去嗰個位置。咁所以呢個就正正就係 guided surgery 啦。我哋喺今時今日咧可以做到提我哋個surgery 點樣 execute 嘅一個好有效嘅方法。 咁呢個 case 咧就係 illustrate 到我成個過程點樣由手術開始之前啦，跟住一路到 surgery 嘅 execution 啦，我哋用 guided surgery 去做呢個 implant，place 呢個 tissue level 嘅 implant，until 我哋擺隻 implant crown 落去咧，就係同我哋原先嗰個 plan 咧係一模一樣。咁呢個就係 posterior 嘅 case 啦。好啦，咁跟住落嚟咧，我仲有另一個 case 啦，第3個 case 咧就想 share 俾大家睇。好多時咧，我哋咧做 guided surgery 咧，其中一個原因，又或者係我哋點樣 make use of 個 guided surgery，令到個手術更加安全嘅其中一個原因，就我哋希望個 guide 幫我哋睇到一啲我哋睇唔到嘅嘢，包括一啲 hidden 嘅 anatomical structure 啦，例如呢個 sinus case。我哋知道 upper posterior implant 經常都會遇到 vertical height 唔夠，我哋需要升 sinus 嘅情況。當我哋望住呢片牙肉嘅時候，我哋準備要起個 flap， 到底我哋個 implant 擠落去嘅時候，幾時先至會 hit 到個 sinus 呢？我哋今時今日當然會用到好多嘅 CBCT 或者係一啲 implant planning software 去幫我哋去設計啦，設計我哋個 implant 擺喺邊度啦位置。咁呢個 case 咧，我哋就設計咗擺咗喺一個 upper posterior 嘅位置咧，係好接近我哋個 nasal sinus 個 maxillary sinus 嘅。咁 three-dimensionally， 今時今日我哋都會睇埋個 3D 嘅結構，我哋都 exactly 知道到底我哋要擺個 implant， 到底我哋要開一個lateral window 個位置喺邊一度㗎啦。甚至乎，如果你話我想睇埋另一邊睇埋個 dimension， 我哋知道距離係幾多。當我哋喺個電腦上面已經見到晒呢啲 dimension 嘅時候，咁我哋當做手術嘅時候，會唔會又真係可以跟得到？又或者點樣可以有效咁樣將我哋已經預先 merge 好嘅嘢 transfer 到去我哋真真正正做手術當刻呢？甚至乎我哋可以反轉個 sinus 睇埋去 medial surface， 因為我哋若果係要做lateral window sinus lift 嘅話，我哋希望將個 membrane由 lateral 去到 medial 咧，成個 membrane lift 起晒。medial surface 有冇啲咩特別嘅地方咧？我哋都可以睇到晒。咁透過我哋做個 implant surgery 嘅時候咧，我哋可以設計一個 sinus guide 啦。咁 sinus guide 其實係一個坦白講係一個唔容易設計嘅手術配件。但係當我哋有咗呢個手術配件嘅時間，我哋擠落病人嘅口裏邊咧，我哋可以好有效將我哋設計好嘅要開嘅sinus window 咧 transfer 過去實際嘅 surgical site， 同埋我哋有晒所有嘅 dimension 啦，包括我哋每一個位置大概個 bone thickness， 咁變咗咧，尤其是係一啲可能係一啲初開始去掌握呢個手術嘅醫生咧，咁呢個係一個好有用嘅一個輔助工具。咁當我哋真真正正開到手術去見到病人嗰個骨床嘅時候， exactly 邊一個位置開呢？一開始可能我哋已經設計好晒，但係如果我哋冇一個工具去指示我哋嘅時候呢，當刻可能都會有啲迷茫。咁透過我哋用 surgical guide 嘅 technique 呢，就可以將嗰個 dimension 直接 transfer 落去。咁同埋咧就可以咧係 compare 翻我哋手術前嗰個效果咧，會睇得到其實咧我哋係可以咧 copy and paste 將件事咧擺落去。咁之後其實都好簡單啦，因為接住落去都係搬字過紙，去將個 sinus 點樣 lift 起 ，and then 喺裏邊擠 bone graft。咁我哋睇一睇術後嗰個 CBCT， 你就會見得到我哋係可以 as plan 咁將病人 nasal sinus 個 anterior wall 同埋 inferior wall 成功咁 lift 起，去將嗰個位置咧鋪翻骨粉。咁呢個就係sinus guide 嗰個作用。咁最後接住落嚟最後一個 case 咧，就係一個嗱，雖然我哋講 daily practice 啦，咁我哋相信有啲醫生咧 daily practice 咧都唔多唔少會遇到好多病人咧係會全口冇牙啦。全口冇牙嘅 case， 咁我哋咧可以透過用 guided surgery 去做。例如呢一個病人佢本身上下都冇晒牙，戴住全口假牙，當然食嘢會好唔方便啦。咁隨住時間，佢都會希望可以重新有翻副實淨固定嘅假牙。咁今時今日我哋會知道咧，如果係用一個手術嘅形式去放 implant 咧，每一個 implant 嘅位置或者係角度咧都好重要。尤其是如果係嗰個 implant 嘅位置係好近 anatomical structure， 最主要都係 nasal sinus 嘅位置啦，又或者係若果係下顎嘅話，就係個 ID canal 嘅位置啦。咁都會好影響我哋判斷到底應該點樣去擠呢個 dental implant。咁透過手術設計導板設計，我哋可以將個導板擺落口裏邊，跟住咧按照導板嘅設計咧，去順利安裝預先設計好嘅 implant 嘅位置。咁實際上嘅操作咧，我哋可以好快咁睇一睇。咁當然首先我哋要將個手術個導板咧，好順利咁固定喺個病人嘅口裏邊啦。咁實際背後咧，亦都係有好多個 technique 需要咧去配合，令到我哋咧可以好準確將個導板擺到落口入邊，固定好。跟住接住落嚟咧，我哋咧就會係將個跟住按照手術導板上邊嘅一啲鑽孔啦，去放我哋嘅植體。咁當做完晒手術之後咧，其實咧我哋會可以好平均咁樣將我哋嗰個 implant 咧擺喺一個適當嘅位置。最主要我係想希望俾大家睇到呢一個 slide 咧，就係咧，當我哋真係例如喺圖畫嘅左手邊，我哋咧係 plan 咗好幾支嘅 implant 嘅位置 ，and then 我哋真係 execute 咗個 surgery 之後咧，實際上我哋將兩者 match 翻埋一齊嘅時候咧，大家會睇到咧個 consistency 都係好高㗎。咁如果你話我哋喺 freehand 做呢個手術嘅時候咧，如果我哋真係要徒手打 implant 打落去冇問題，但係 at the end 點解我哋會做得到個 prosthesis？ 並唔係因為我哋個手打落去好準，而係因為做完啲 implant 之後個 lab 好叻，可以咧用個 prosthesis 咧去盡量去就翻一啲 implant 嘅 position。咁但係其實背後可能 sacrifice 咗好多嘢，例如係本身設計上邊點解你會設計呢支 implant 嘅角度，或者係佢個旋轉嘅角度去咁樣擠啦。咁如果係我哋預先已經係花咗好多時間睇過晒病人嗰個 3D 嗰個available bone 嘅 architecture 去設計 implant 嘅角度，而如果我哋真係可以 follow 翻呢個結構 implement 翻出嚟呢，個 prosthesis 相對嚟講會做得比較 predictable 啲，同埋咧成個 surgery 咧都會係好 smooth。咁呢個咧亦都係好需要咧 guided surgery 呢個technique 去幫我哋完成呢個手術。咁當然 at the end 我哋都要 compare 翻嘅就係咁 guided surgery 係咪真係咁神奇嘅一樣嘢咧？咁喺 literature 上邊我哋都睇得到，其實若果我哋真係要 compare freehand 做 implant 同埋guided surgery 做 implant 嘅話咧，事實上我哋真係冇辦法做到 guided surgery 嗰個準程度，特別係 implant 嗰個insertion 嗰個 angulation。咁同埋咧喺一啲systematic review 裏邊咧已經睇得到咧，我哋咧無論係 freehand， 即係無論係唔同嘅dimension 啦，例如係 angular deviation、coronal deviation、apical deviation， 我哋 freehand 同埋 guided surgery 比較之下咧，我哋都係咧 statistically significantly 咧係 inaccurate when compared with 我哋嘅 guided surgery。咁所以換句説話講，其實我哋都好清晰，今時今日咧有好多嘅 evidence 話俾你聽咧。若果我哋真係要 execute 一個 surgery 嘅時間咧 ，guided surgery 嗰個準程度咧，個 predictability 咧係會好高嘅。咁去翻嗰個問題就係、到底邊一啲 case 先至應該要做 guided surgery 咧？咁好多時咧，好多人都會話：我若果係 full mouth 嘅，咁都 make sense 喎。我一次過打20支 implant， 咁啊準啲好啲嘅。但係咧，原來咧，我哋做 guided surgery 咧都有個 learning curve。If in case 我哋做 single implant 嘅 guided surgery， 我哋都未係好掌握嘅時候咧，突然之間有個 case 入到嚟，我可能要打一個 full arch 嘅 implant 咧，其實咧嗰個 guided surgery 咧會令到你好 heavy 好吃力。所以咧喺我嘅 understanding 裏邊咧，其實咧 single implant 嘅 case 咧都係一個好好嘅機會咧，去俾我哋咧去 train 點樣去熟習成個術式，點樣去 carry out 成個步驟。咁當然唔係淨係做手術嗰刻啦，因為 guided surgery 講緊嘅其實係我哋clinician 喺個電腦裏邊 start from scratch， 喺個電腦裏邊點樣擺個 implant，position 嘅 implant，according to 我哋 desired 嘅 prosthetic design， 跟住再設計埋個 surgical guide， surgical guide 本身嘅設計點樣可以順利令到我哋做到個手術，又或者會唔會有啲乜嘢 surgical guide 嘅設計令到我哋做手術當刻會遇到困難？咁呢啲都係一啲 training。咁到真正個 surgical guide 出到嚟之後，我哋去 execute 個手術，先至成件事會 complete 得到。咁少少嘅 conclusion 啦，其實 guided surgery 咧 at the end 咧都係希望成個手術順利啲、安全啲，病人少啲 complication。咁 add on 嘅係咩呢？我哋成個手術其實可以呢，喺一個若果當我哋順利或者我哋成熟咁運用呢個技術之後呢，我哋可以呢喺一個快啲、短啲嘅時間裏邊，甚或乎呢可以 minimally invasive 咁樣去 carry out 一個手術。例如有啲 case 我哋可以透過 guided surgery 去做一啲 fabless 嘅步驟等等。咁最後啦，我哋做 implant 都係務求希望快靚正，做完之後少手尾。好啦，點樣可以做得到呢？ ITI 2008年嘅treatment guide 已經講過咧 ，implant 嘅 errors 不外乎4個 element。第一 patient factor， 可能佢病人本身身體狀況或者佢個牙床狀況，令到個 implant case 係 challenging， 或者高啲機會會有問題，有 complication。再講嘅就係 treatment approach。treatment approach 講緊嘅係我哋點樣去 carry out 呢個 implant 嘅 surgery。我哋到底係做一個 delay 嘅 healed rich 嘅 implant 啦，抑或係一個 immediate implant with 一個 higher risk 呢？今時今日 treatment approach 某程度上，除咗係 clinician 有 based on 自己 experience 去揀之外，其實病人好多時都會有自己嘅睇法。有啲病人入到嚟嘅時候，已經基本上都係問你：我 day one 入嚟 ，day one 出翻去，我已經係要有翻隻牙㗎啦，你做唔做得到呢？咁其實咧 treatment approach 上面都有機會令到個手術本身難咗，同埋會 at risk。咁當然第三個 element 就係 biomaterial。我哋知道，如果我哋擠落去個 patient 嘅口裏邊嘅 biomaterial 係一啲 evidence-based、well-proven 嘅一啲好 successful 嘅、好 safe 嘅 material 嘅話，當然我哋嘅手術會成功啲啦。但係最後咧就係我哋 clinician 本身。咁每一個 clinician 擺 implant 其實都有 learning curve 嘅。如果我哋學習一個手術嘅術式嘅時間，我哋係再多一個 element 去幫我哋令到個手術係可以安全咁進行嘅時候呢，咁會令到成件事呢係更加穩陣。咁所以呢，喺呢一個 context 底下呢，我覺得咧 guided surgery 呢會係一個好好嘅工具咧，去幫大家呢係放一個好穩陣嘅 implant。咁講到呢度呢，咁我哋暫過一段落呢，就都好多謝大家嘅時間。咁接住落嚟呢，之後呢，仲會有好多一連串嘅好充實嘅lectures 咧，同埋 live demo。咁請大家繼續留意 Acumen Dental Academy。多謝，多謝。
Good morning. Thank you for being here in such large numbers, and maybe we can get a couple more people. My name is Dr. Sandra Hulak, and I'm going to talk to you today about two things, and also including some demonstrations. First, we're going to talk about rubber dam isolation, and later about, direct posterior composite restorations, how you can make them beautiful, but also in a time-efficient manner. Okay, so first things first. When it comes to rubber dam, I think there is a big kind of fear factor for most people because they feel it's taking too much out of their time. But as with everything in dentistry or otherwise, there is just a learning curve. And once you have incorporated rubber dam into your practice, I think you're not going to go back. If you're doing a lot of adhesive dentistry and you're not using rubber dam, I think you're kidding yourself that you're getting, a just as good result by isolating with a saliva ejector and cotton rolls. It is just not so. And we recently, although it took a little while, have actually also got the literature to support this, that you get significantly stronger bond strength if you are actually using a rubber dam. Okay, so how do we do this? These are my favorite tools. So I use a dam called IsoDam, which is latex-free. It is, like everything, pretty hard to get your hands on it in Hong Kong, but you can order it from Germany, for example. The reason why I use it is because it's virtually indestructible and it's incredibly stretchy. And obviously being latex-free is another added benefit. I use liquid dam if I have a little leak. I use Teflon tape a lot. And clamp-wise, I occasionally use a Kerr soft clamp if my patient isn't anesthetized. But my favorite clamps for quadrant isolation are the 12 and 13A wing clamps with serrated edges because they hold really well. I might use a number 2 wing clamp if I need to stabilize the dam on the other side a bit more. And then I use a lot of Brinkers B2 and B3 for posterior crown seats, for example. And obviously the very famous Brinker B4 for veneer seats. When it comes to your rubber dam or your clamp forceps, I think in the posterior, using just one of these, standard clamp placements tools is sufficient. But one of the things you notice is that when you look at the picture on the lower right, how the tines of the clamp holder on the right open a lot more than the one on the left. And that is because we've cut off the ends of these things, so you can open them a lot more, because there's often do not sufficiently open the clamps enough to be easily seating them on molars. If you really want to get into rubber dam isolation and you're doing a lot of your veneers or anterior seats under rubber dam isolation, then I really recommend that you're buying this Hugh 3D. It's the RDF4, and it's by far the most superior clamp placer in the world. So Hugh 3D is here today. Ask them if they have it and if they can give you a discount. I mentioned the importance of having the right quality of rubber dam. So here I just tried to stretch the shitty green dam, which is available pretty much everywhere and is used in dental schools, and it's just not stretchy. Now see what the IsoDam can do. This does not rip, this stretches beautifully. So for quadrant isolation, I just used the 12 and 13A, and I have my assistant pre-punch the holes. For the quadrant isolation, it's absolutely fine to just use your template, okay? Just make sure that your largest hole is on your anchor tooth. As I say, occasionally, I will use a soft clamp if my patient isn't anesthetized. Now, one of the important things is when you place your anchor clamp is that you must secure it with a floss tie, okay? Then you can stretch the clamp, the rubber dam over the clamp, and once the clamp is sitting securely on the tooth, you will have to remove the floss tie, but you have to do it like that. And ask me how I know this, because of this. So this is my patient, and I've been using rubber dam for 25 years, And this is my patient that swallowed a clamp. Cue in, emergency appointment at the hospital, and the clamp being endoscopically removed by a surgeon. So that was a bad day for everybody involved. So please put floss ties on your clamps. So once you have everything in place, if you have a great rubber dam, you don't need to do anything like blowing it and using a flat plastic to invert it and all that bullshit. You can just invert the dam with a little bit of floss. And frankly, a good rubber dam will basically self-invert. So you sometimes have to put a single floss tie underneath the clamp to invert the dam completely in order to avoid leakage. And I like to hold my dam in the front with just a little bit of, cut up dam material. And sometimes, I also put an extra ligature there if I want to have more retraction. When it comes to actually then doing your restorative dentistry, like you're prepping under dam, I would really recommend that you just stuff in some wooden wedges into the interproximal to protect your dam from burr damage, because that's a bad day if your burr hits the dam and the dam is ripped and everything. As I say, so single floss ties are very good to prevent a little bit of leakage if your dam isn't fully inverted. And obviously, the liquid dam also around your anchor clamp can be used. So single floss ties go like that. First of all, when your floss comes out of the dispenser, it's curly, right? That's really hard to tie. So what you do, you just pull it a couple of times and it straightens out immediately. This way, it's much, much easier to get your floss tie going. So now I am just doing a single floss tie, and these are, very good for, added retraction under clamps, or also when you're doing composite veneers in the anterior. We often have a problem when it comes to second molars using our specified 12A or 13A anchor clamps, and it's a big problem, particularly if you want to do, say, a DO on a 6 or an MO on a 7. You will find that the wings of your wing clamps are in the way. Some people recommend just cutting the wings off these clamps for this scenarios. I don't really like doing that, because I like the extra retraction those wings give me. But what I often do is that I secure my dam with my classic anchor clamp and then switch out the clamp for a brinker clamp, okay? I find that is the most practical way of doing it. Now we're coming to arch isolation. So what I said before, you can definitely use a template to just, do quadrant isolation. But when it comes to irregular tooth positions and also full arch isolation, I think you should mark the dam individually for the position of the teeth. My trick would be, if you're seating a lot of units, to actually, if you have a unit that you need to seat on 6, you need to just seat that separately in first, because that's what you want to put your anchor clamp on later. Trying and isolating a dam from 1/7 to a full upper arch from 1/7 to 2/7 or 3/7 to 4/7, your patient is not going to like that. They cannot swallow anymore. It becomes incredibly uncomfortable. One of the things that's important, particularly with the brinker clamps, is that they're pretty flimsy, right? So they lose their tension very, very, very quickly, but you don't want to have to throw away the clamp, because clamps are expensive. So you have to do two things with these clamps. First, you just use some ortho pliers and tighten them a little bit to retension them. And then the other thing you have to do, particularly if the clamps are very new, or you have used them a lot, is that you have to resharpen the tines of the clamp itself, because you want it to be having a really acute angle to grip onto the tooth. And for that, we just use a carbide burr. You will have despite everything you do, you will have situations where your clamps just do not grip properly or have a little bit of mobility, and I would advise you to never, ever, ever start seating if you have a wobbly clamp. So there's a way to stabilize the clamps against each other. What I did there with just a piece of a micro brush, which I cut and then, attached to the clamps, or sometimes just bonding the clamps onto the teeth with a little bit of liquid dam. When it comes to now cementation of upper arches, or any cementation, I would seat two units maximum against each other. Trying to seat a whole arch under rubber dam is close to impossible, okay? It becomes very messy, but still, I remember the times when I wasn't using dam for seating, and a veneer case took me 4 hours to seat. Now, with rubber dam, I'm down to 3.5 hours, so it makes your jobs actually faster. The seating procedure goes like this. You air abrade your teeth, and you protect the neighboring teeth with a hoorband because you don't want those to be air abraded. And then you etch, you bond, then you switch, you apply the etch, you rinse everything, and then you put your Teflon bands for isolation. Because if you try to do the etching and the bonding and all that with the Teflon in place, it's going to get wet, it's going to rip, and it's going to end up in your suction. So that's a bad idea. And sometimes you just have to do everything. You have to throw everything at a certain quadrant. So here I'm using Teflon for extra inversion. I'm using the liquid dam. I'm using a 12A clamp. I'm using a floss tie, and I'm using a B4 for that anterior unit. I just talked about the double floss ties, and I can maybe demonstrate those later as well. But these are the ones if you need a maximum gingival retraction. So this is how you do those. And the very good news is that they're actually self-tightening. So you don't have to, you just pull on them like that, and they tighten on its own around the tooth. When it comes to anterior composite veneers, which I do a lot, or any anterior isolation where you're not seating, but you actually want to add composite to the tooth, you have the problem quite often that obviously the ligature needs to have some kind of convexity in order to hold. Otherwise, it's going to start slipping up again. And you can use this little trick by just putting a little bit of flowable temporarily in these areas to slip your ligatures underneath. And sometimes, particularly if you're doing composite veneers, what ends up happening that your composite will then get caked in the knots while you're doing it, and the knots are in the way. So actually, you can just pull them to the inside. Or in cases where you have a lot of recession, I actually will build the cervical areas first and then put my dam on. And a great tool to do the cervicals first is this Unica matrix from Stile Italiano. Okay, and that is just everything about the dam, and now we're going to demonstrate a little bit, okay? Now this doesn't work, right?
I think it's gonna be clipped a little bit higher.
Test, not really. Somebody needs to.
Good morning, ladies and gentlemen. The Launchpad Day Product Insights, presented by Unit Magic Company Limited, will begin at 11:30 a.m. Please join us at the convention foyer. Thank you.
There's no image. Ah, okay. Okay, fine. So this is how we do quadrant isolation. Come on, Haley. Put the clamp in. As I've told you before, the clamp and the dam are put on together, but the clamp has to be secured with a floss tie. Okay, what we're doing here is we're putting a little bit of jelly on the underside of the dam to make it a little bit more, you know. Okay, this doesn't. You're choking me right now.
Huh?
No, she's choking me.
Is it okay?
I don't know. Can anybody hear me? Can you guys hear me? Not really, right? No. Sorry. Take it off. You have to just hold it against me. Please take it off. Please. Yeah. And just. Okay, so now I'm placing this. I'm now securing this. Now this is on now. Can I have a, that I wouldn't use. You know what I use? I use the, you forgot to bring it. Okay, good. And now Haley and I are just gonna stretch this over. Stop. And as you can see, this dam, because it's expensive dam, literally self-inverts. So you don't really have to do much about it. Okay? Now, if I had a slippy contact on the mesial of this 4 and this dam would continue come up, there are two things I can do. Can I have a scissor, please? We're gonna just cut a little corner of this, and then we stretch it and put it here, and that's gonna hold our dam. So that's one way to do it. Now can I have a number 2, please? The other thing I can do, but my patient needs to be slightly numb for that, is to place a stabilizing clamp on the other side, like this. Okay, so that is quadrant isolation. That takes literally 20 seconds in my practice. So now to the floss ties. Somebody needs to tell me if I'm still there. See what Haley has done? She's taken the floss and did this. So now the floss is nice and easy to tie. So it's really just easy. You make a loop. This is so much easier when you're not wearing gloves. And there you have your single floss tie. Now, if I wanted to put that, say, on here, what we would do is go through the contacts. Now, Haley holds the inside with a flat plastic or an IPC, and I tighten this. So I get full inversion now of my dam in the sulcus. Let's cut this. And as I say, if this is in the way, try and slip it to the inside. Now, excuse me, can I have a tissue? Now, the double floss tie has, as I say, a lot more retractive power. You hold it like this, then you invert your fingers like that, till you end up with a loop like this. And through this loop, you just pull another loop. Oh, this didn't work, sorry. Let's do this again. Can I have a new piece? I don't see very well. Let's hang on. I can do it. This. Again, it didn't work. Okay, Haley, give me a new piece. I'm sorry. This is obviously the principle of SOT when you want to demonstrate something and it doesn't work. Yeah, but see, I can't see. All right, I finally got it. And now we're going to try and put that around the 6. And Haley goes in again. And I just have to do this. Sometimes at the end, I will tighten it more. And I get a lot more retraction than I would ordinarily get with the single floss type. Okay. So this is, the end of the quadrant restoration. Now we can take this off and go for the arch restoration. Okay, so full arch, 6 to 6. Did you bring something to mark? Oh, you already did it. Okay. Well,
Or you want to show marking on?
I would like to show the marking because this template is a bit big. You know something? So full arch, we would stretch the dam in the patient's mouth like this and then start to mark. Start on the one. Okay? Because this is actually drastically different to what you would get from a template,
Presented by Union Magic
which is much, much bigger.
will begin at 11:30 a.m. Please join us at
Yeah.
the convention foyer. Thank you.
So Haley is punching now, and she uses the largest hole that the punch has on the anchor tooth, which is the 6, but much smaller holes on all the other teeth. Now she puts the first clamp in. Just use this one. And she has to put a ligature on that clamp. Okay, now we start.
Let me move.
So now we've lost that through everything. We can get rid with that. Hold. And as I say, if you use a good dam, nothing's gonna rip. And now the airway of the patient is protected, so we don't need to put ligatures on that one. So we're just placing the second clamp and bingo. Okay. Now we would, as I say, go back, floss, and try and invert the dam a bit better. Can they see? But we still don't have sufficient retractions if we wanted to put some veneers on those two anteriors now. See, it's not all the way down. So this is where we're going to now put our Brinker B4s. So this is, I live in the real world, so these clamps have been used in my practice. So can I have the ortho pliers, please? And if you, I don't know if you can see that, but one is much more open than the other. So I'm going to tighten that one a little bit. Sorry, just need to grip this better. So now it's nice and tight. And remember, ordinarily I would now sharpen the tines as well, but I'm not going to do that. And for placing of the Brinkers, I always use that Hue 3D because it's just much easier, it has lots better tactility, and it's very easy to disengage the clamp from the clamp forceps. So what we do, we put one here, we put another one here, and this would be now ready for a veneer seat. Okay, if we were to seat a veneer on this. If we still haven't got sufficient retraction, then we would re-invert the dam again with a little bit of floss and maybe put a floss tie underneath. Okay, so this brings me to the end of this presentation. Does anybody have any questions?
Let's get this ready for the conference.
It's small, but it's like very friendly.
Okay, guys, exciting new stuff ahead. How do you do posterior composite restorations that look really good on Instagram and won't bankrupt you because they take so long? So I first want to talk a little bit about case selection, indications, and materials, because despite what you see in practice, not every tooth really can have a direct restoration anymore. So how do I decide if I'm going for a direct composite or if I'm going for an indirect onlay or porcelain crown? So there are two things we have to look at. One is patient factors and the other one is tooth factors. So patient's age definitely plays a part. I'd be much more inclined to put a onlay on a patient that's a little older. Whereas in the younger patient, I will probably try and see if I can fix it with composite first. Patient's bite force is a big deciding factor. So we do know that lower sevens, for example, and upper premolars have a tendency to fracture more than other teeth. The lower molars, obviously, because they are the most distal teeth in the lower arch, the closest to the fulcrum of the chewing system, so they receive the most load. And the upper premolars because they flex a lot when you chew. So these are the teeth that crack the most often. So if I have a crack in a tooth like that, I'd be more inclined to go directly to an onlay. And obviously, if your patient has symptoms or not. If a tooth is symptomatic and reacts to pressure on chewing, then the crack is probably, if you have a cracked tooth, the crack is probably propagated already into the dentin, so that tooth cannot really be fixed with composite anymore. It should have an onlay. The size of the existing restoration or decay plays a part. The location of the tooth in the mouth, like I've said before, lower molars and upper premolars. And then we have to also make a decision what we're going to do with regards to adhesion. Are we going to do self-etch or etch and rinse? Now, the thing is that the etch and rinse approach, although people think it's the most tried and tested, is actually really incredibly sensitive to operator mistakes. Okay, and if you're going like for 7th generation bond that can do everything, like it bonds, it etches, it bonds, it does this, it hydro D, you know, the thing is, like Albert Einstein already said, which is it is okay to make things easier, but not easier than possible. So I do not believe in these kind of bonds. I'm a 4th generation person, okay? But I am a 4th generation person that does not like to etch their dentin, so I am actually using a self-etching primer and a bond, and that would be SE bond in my clinic. Because I don't like to etch my dentin because we have the problem with MMP release and, you know, the bond to dentin breaking down over the years. And although we still have that to some extent, also with a self-etching primer, not as much. So technique. Instruments I use, you know, you don't have to spend a lot. I mean, you already have all that in the practice. That's, you know, a microbrush, IPC carver, a straight probe, and a perio probe. That's really all you need if you know, want to do nice looking posterior composites. But if you want to invest a little bit, I would buy one of those. So we either have, you know, the Stile Italiano su Fissura or the TNT TAM from Hugh Friede. Hugh Friede is here today. See if they have it. And now we're going to go into case demonstration quickly. So I am a big fan, and I cannot do this here today, but I do believe that all adhesive dentistry should be particle abraded because your bond strength is going to be so much higher, okay? So there's plenty of literature out there that shows that you air abrade your enamel and your dentin, your bond strength is far superior. So just buy yourself a Rondoflex. They don't cost a lot, or some kind of prep start. I do love using desensitizer, because not only will it occlude my open dentinal tubules, it also, so it's supposed to get rid with sensitivity, post-operative sensitivity, but it also sterilizes my dentin 100%. I do not use any liners on my dentin. I haven't had the need to do so. I've been doing composite fillings like that for the last 15 years, and ask me how many cases of sensitivity I had. I don't think we can remember any. And if you think that it would interfere with your bond strength, it does not. Okay. Okay, and now we're going to the demonstration. So like I said in the previous lecture, it is super important that you secure your clamp with a floss tie unless you want it to end up in your patient's lung or stomach.
Where is Sergey?
No idea. So I have taken the liberty to prepare that cavity already. But remember what I told you, if you were preparing the cavity, protect your dam with a wooden wedge. Like I am showing here, okay? There's the wooden wedge, because you don't want your burr to touch the dam in the interproximally and rip the dam. Once I've prepared my cavity, I do some air abrasion, and another thing I like to do is just polish the bottom of the box a little bit with a strip to make sure that there is no kind of spicules of enamel standing up. This also will make the subsequent application of my matrix band, of my contact matrix band, a lot easier. This is very close to life now. What you sometimes have to do, if the contact is a little tight, you have to torque the teeth apart. And obviously your patient is anesthetized for that.
Small one?
Need a small wedge. I like to put the wedge first. Some people do it later. It's up to you. Contact matrix is a must. Then we burnish our contact point, and we have a classic dilemma whereby the matrix doesn't adapt here properly. So now we have to use a little Teflon. we use a little ball of Teflon. To get better adaptation of our matrix here. I need another ball. Let's pretend this is adapted now. So now we would do our bonding process. Now we do our air abrasion, our gluma. I do a selective enamel etch because I like, to etch my enamel, but not my dentin. And then I am doing my bonding procedure. So here's the selective enamel etch. Let's pretend this is SE bond, but for some reason we only have normal bond here, which is okay. I don't know if there's that much to learn. So what I'm doing now is a procedure known as snow plowing, where you apply a tiny little bit of flowable into the bottom of your box, and then you put your packable on top. And what you get is less shrinkage, better adaptation, and theoretically, a better bond down there. This is going to set like crazy. So if you need something. Now I'm doing a procedure known as ridge rolling, whereby I shape the ridge at an angle towards the matrix band to reproduce the proper rounded anatomy of a proximal ridge. Because if you left it like that, your patient has problems with flossing. They can't get the floss in. So my ridge is done now, and I'm just curing it. The next thing I do, I put a little bit of flow everywhere on the bottom of my cavity to create a very good hybrid layer. Now I can actually remove the ring and the band. Let's pretend we don't have an overhang here. Gonna deal with that later. I would leave the wedge in at this stage because sometimes, despite the dam, you get a little bleed now, and it comes. The dam is like a suction device. It will then kind of come up. You don't want it. Leave the wedge in until you're all done. Now we're going to start to build our occlusal surface cusp by cusp. So that is where you actually spend your time on. Not only is it going to give you a much better composite filling, where you have much less problems with S factor and sensitivity due to shrinkage, it also will give you a much more beautiful occlusal surface that you then don't have to adjust the shit out of. Okay? The occlusal anatomy of this typodonts is fairly simple, but if you want to, you can absolutely go to town after this next step. Now I would use a highly filled flow. Let's pretend this is a highly filled flow, which it's not. So I would use GC's injectable for that and a thin tip and add a little bit more detail if I wanted to. So when we're done with that, now we're getting our filling Instagram ready by applying some Fischer stain. Because if you want to put your posterior composite on Instagram, you cannot not have Fischer stain. do not apply your stain undiluted. It's so dark, okay? So what I do, I press a little bit out, and I take my wetting resin. Where is my wetting resin? Which has set now. So this is Didier Dici's from the Inspiro kit. It's a very highly filled stain, so it actually stays there, which is nice. You can put it on the surface because I do not have time to put my stains under a layer inside my my posterior composite. As I say, we gotta make some money, people, as well. Hold this. So this looks terrible because it's way too much.
Okay.
And now we are supposed to set our last layer under air inhibition. Yeah. Now I'm going to take my wedge out and deal with this terrible overhang. And obviously this is also only happening because I'm demonstrating this here now. This really doesn't happen clinically. Can I have the 12 plate?
Roll it out.
Yeah. Now I need a slow speed. You have a slow speed? So the first thing I deal with is my ridge with a red. And you have to put that on backwards, like this.
Maybe too high.
Well, then change it. Yeah, that's good. Once I've done that, I go a little bit on my occlusal. Can I have the Goldie? So my ridge is too high. And at the same time now I'm going to go a little bit over the margins, just make sure that there is no composite stuck onto the tooth. Okay. Blow it. And now we literally just have to polish. And in the mouth, I would do that wet so that I don't have a ton of polishing residue. Now I would check my contact point. Floss, please. This is a good way to check if it has enough oomph. When you start to like do this, you can do this, and you really have to pull to get it out. Okay. Now we would just rinse it.
Rinse it.
Cut off the dam. Start checking your occlusion, and then obviously, hopefully, not having to take away too much of the anatomy you just built so carefully. Give me a little jelly. I don't do this in the mouth, I just clean it now so you can see it. Okay, and that's done. This will be for me a half an hour procedure maximum, okay? Maximum. Yeah.
You mentioned you use a few sets of days.
Yeah, Gluma.
Yeah.
So if you're interested, we have to
So you don't have to rinse it off. You just
No.
do you manicure it? Do you have to manicure it?
No. Gluma is your first step, right? Gluma you just put on your dentin.
yeah. So I'll be
Rub it in, it just disinfects your dentin, and it also includes you just open the entire pupils. And then you just then you start your bonding procedure.
Okay.
So it's air abrasion, selective enamel head, Gluma, Essibone primer, Essibone bond. Then cure, then start your layering process, which I do with building the proximal ridge first, to convert my cavity into a class 1. It also takes out polymerization stresses, and I do that with this snow plowing technique, but I put a little bit of, trouble, because there's nothing more frustrating than when you start doing this, and you make these beautiful ridges, and then you notice on the x-rays that you just have a gap there because your instrument pulled the compass a little bit away from the bottom of your box. So then you see in your x-rays, man, I have a small gap there at the bottom of my box. So doing it like this, you won't have that gap anymore. Then once I've done my ridge with the ridge rolling and the proper contouring, and I set it, then I am covering the whole rest of the bottom of my cavity preparation with a layer of bond. Spread that, cure that. Then if I have a very, very big cavity, then I would now use a bulk fold to make up the space. And then just when it comes to your occlusion surface, then I layer my cusp by cusp by cusp. Because you want to do that because it gives you a beautiful anatomy automatically, and it takes out polymerization stresses. And doing it like that, taking the cusps of the adjacent teeth as a guide when it comes to the depth of this, you also will have a lot less issues with having to do a dentistry, having to adjust the opposing beforehand because if the filling is underpunctured, you have to. There will be an over-erupted opposing teeth, all this kind of stuff. But I'm going to talk about all that in my course.
So no need to clear up the composite. You're not using clear composite.
Sorry?
Not using heated composite.
No. I'm over that. I'm using heated composite for sealing. For sealing my restoration. Something not veneers, only posterior onwards, and only if I'm in the mood. But no, I'm not using. I'm using this stuff. This is, and there's not much simple stuff. It's just a benefit consistency of the best posterior composite in the world. Because it just behaves. It's not sticky. It works well in Hong Kong. It just does everything you like. I have used Pulpy for 5 years now. I would never use anything else until they show me something better.
So it's the 1/6
Yeah.
music?
MO music. And you know, this is like, I didn't really do a great job with it.
So
But
there's no stain in it?
I put the stain in. Because I think it's, because I think it's good. And then when the patients don't appreciate it, but your Instagram will really. Stains are for Instagram.
testing，要咁樣先聽到，要反少少出嚟先，咁得唔得？係咪？揸住係咪好啲？揸住好啲，揸住啊！OK，而家咁樣 OK。好，繼續。佢要向上面啲毛咯。
你放手你先。哦，係咪？
而家我坐喺度，係而家講嘢，但係係咪好細聲？係咪好細聲？係咪都係細聲
？OK，好過
係嘛？唔係我可以揸住嘅，而家 OK，
而家
OK，好得，好啊。但係我講嗰陣時咩先？我用呢個 remote。你覺得我應該講中文講咩？我收埋你聲。講英文咯。Okay. Let's start. Okay. Right. So actually, it's my turn to do a quick demonstration on onlay. Okay, which is actually what I do every day. So I'm Dr. Edward Tam. So we're speaking at the Acumen Dental Academy booth. So we are a new training center. We start off in March this year. Okay, so we have a dedicated facility to find out a bit more, scan us, and get a brochure. Then you'll see actually who we are. So basically, actually, we are like a teaching center. So we arrange lectures, hands-on courses, and sometimes even together with light surgery. So one of the things I teach is actually how to prepare onlay, okay? Because what we find is that actually that a lot of dentists are doing onlays at the moment, and but onlay is actually what we do for most of the time for posterior teeth because it's conservative, it saves a lot of tooth substance, and we make use of adhesive dentistry as well. And together, actually, we'll talk about digital workflow as well. So digital workflow actually allow us to do an onlay in less than 2 hours. Okay, so this is all the advantages of doing onlay. So here's that. Okay, so you see our logo, Acumen Dental Academy. We are actually in Central, right above the MTR station. So today, like I said, we talk about the onlay demo. And we have two sponsors, okay, because most of the time we use EMAX, and which is actually the lithium disilicate, is perfect for our onlay. And my laboratory actually is Vanguard, you can see right next to us, and they can allow us to do same-day restoration within 2 hours, okay? So this is me, okay? I'm just a general dentist, but my specialist interest is in implant and now digital dentistry. So why onlay? Because we just do a quick lecture first, okay? Because we don't want to do bonded crown anymore. And I see this all the time, okay? You have the porcelain breaking away from the zirconia coping or metal coping. And if you look at the reason why, is because the porcelain on top of the coping is only like about 100 megapascal. If you measure the bond strength, the fractional strength of the veneer porcelain is very weak. Compared to like a monolithic restoration, and then you have it may be only like about 400 MPa, but it's in one single layer. If you have the two-layer restorations like a bonded crown, then the top layer is very weak and that tends to break. And we talk about how much tooth substance you can preserve. If you do a full crown, according to the paper, then you reduce the tooth substance above the gum level by 74%. If you do an onlay, that goes down to only 39%. So basically, you are saving 35% of the tooth substance. This itself, if you tell the patient, if it's your own tooth, what will you choose? You will probably want to do something more conservative, right? So these are all the advantages. So we won't actually talk about all this in details, but we can see the list here. We do run regular workshops, okay? So it will be like a half day. We will talk about onlays, why we do it, and all the material and some papers, research, okay? Then we will have hands-on on how to prepare the onlay, which I'll be showing in a minute. And then also we talk about cementation, rubber dam restoration, how to scan, for example, as well. So the whole workflow, we can do that in one afternoon. So just join us, okay? If you like us, we'll send you the program when it happens. So like I said, I use Ivoclar Emax, and it's the one with probably actually the longest history for the lithium disilicate. And it has 20 years of experience now. This year they're celebrating 20 years. And this is my material of choice. And it's a glass ceramics, so it's etchable. The advantages of why I use Emax is because you can etch it, you can create micro roughness, and you can actually improve the bonding to the dentin as well. And it's got great aesthetics. So it's more translucent, it's actually look really like natural enamel. And these are the specifics on the lithium disilicate. So there are some clinical tips I want to talk to you about. For the onlay to be successful, the same for any indirect restoration. Number one is actually occlusal clearance. You need to have sufficient space. You need to respect the material. The fractional strength, like I said, is 400 megapascal. But that's not totally relevant because you need to remember, when you bond to enamel, even like a thin layer like a veneer, you can still have very high strength. The strength comes from the bonding to the enamel. It's the same for Emax, for onlay, I mean. If you bond it to the posterior teeth, if you have the ring of enamel, the bond strength is very high, and that increases the strength of the bone. I mean, some of the patients, unless the teeth is heavily fluoridated, the enamel is not even as strong as the Emax. So the Emax actually improves the strength of the tooth. Okay? So with the digital scanner, this is why we do digital workflow. It's so much easier to see if you have reduced enough. If you use a scanner and you do the bite scan, you can actually flip it to the inside and you can see how much reduction you have between the upper tooth or the opposing tooth, okay? And there's some preparation basic requirement. This is things you have to observe. Like I said, number one, sufficient reduction. You also need to have a clear margin. Now, this is a big advantage if you do onlay because the margin is super gingival. So you don't need to use retraction cord. You don't have to like push the gum away. You can actually see the margin very clearly. The other thing you need to do is to have a very smooth surface. You don't want to have sharp corners. With bonded crown, you can still cover it if you have a bit of roughness, sharp corners. But with the onlay, especially with the computer design, you need to have a smooth surface and make sure you don't have undercut. The other things you have to remember, okay, always try to finish on enamel if you can. And I also actually follow the occlusal anatomy. I do not actually just do tabletop so that the restoration will have more or less even thickness. And again, no sharp corners. And if you prefer, you can use a chamfer margin, especially on the buckle side, because that improves the aesthetics a lot. I'll show you example later. And a lot of time you can do a butt joint. Butt joint means 90 degrees joint, okay? But then you might see like a line. So I would use a chamfer, sometimes even like a slight shoulder on the buckle side, and you can hide the margin very well. So this is from Ifocla, and these are the preparation guidelines for onlay, crowns, veneers. So we focus on onlay. So again, actually the same guideline I talked about earlier, and the minimum thickness is 1.5 millimeters. But on the heavy load area, I will actually go to 2 millimeters as well. Okay, so next we're going to quickly go through the steps I do, and then I do the demo for you, okay? So I actually have my burr kit, you can see actually here, and it has 11 burrs. That's not, it's more or less like the minimum. You can add your own burrs. Everybody has their own favorite burrs. If you want to add yours and also some kind of polishes on top, you can also do that as well. But this is the burr kit that I will use in my preparation course, okay? So number one, which is actually the very important burr, is called depth cutter. So you can see the cutting tip here, and depends on which company you buy from. You can actually have different cutting depth, from 1 millimeter to 1.2, 1.5, 1.8 to 2 millimeters as well. So the one I use is 1.5. You can see the cutting tip. There are many companies making this as well. So including in the burr kit here is the one very similar to you see on the screen. And then this one is what I used before. It's from Messenger. So the Messenger one actually has a kind of like a neck, so it helps you to not to overcut. But then the cutting tip is also, like I said, you can change from 1.8 to 2. It depends on how much of the cutting depth you want. So this is actually where we want to use. It's the first burr because we want to make sure we have the occlusal clearance. So sometimes what I do is actually I get the patient to bite on a ticketing paper to mark actually where they have the contact. And that's where I will start first. So I make sure I will have 2 millimeters of reduction at that area, okay? And you can also use different other burrs. I will go through that later on. And one reason why we want to have a smooth surface is because of this. And if the restoration is made by CAD/CAM, remember, the CAD/CAM also cut with burrs, and the burrs have diameter. And diameter actually means that if you have like a very sharp preparation and you need to cut that, then the machine will overcut in that area so that it won't be blocking actually or there's sufficient clearance there. But what it means is that then the area where it has overmill, you will have thinner of the material. So that can cause fracture later on. So this is why we always want to have a smooth surface, no sharp corners, no roughness. And one of the things actually can help is to have something like this. This is a occlusal reduction burr, and you can see it has got a round, more or less like Chinese we call wulou shape, right? So it can actually then reduce the occlusal surface, but with a smooth surface, with a smooth corner, okay? And one of the tips actually I will also give is that I always remove all the fillings, and then I use the flowable composite to build up the floor to block out undercuts. Because number one, for the floor, then you can actually hide all the previous cavity roughness and also the burr mark. Because then with the flowable composite, you have a very smooth surface. And then with the axial wall, if you have undercut, if you use flowable, then you can actually build up the wall, and it means you don't have to cut it away. So it's much more conservative to do that. And then, like I said, during our workshop, we will teach a lot more on that, okay? So this is now my burr kit and my prep steps, okay? And these are the 10 steps, okay? And I'll go through them one by one. Like I said, we'll start with the depth cutter. And to do the preparation, again, this is actually what we want to do. We want to have the occlusal reduction first, then we prepare the box margin, And then we prepare the margin on the inside Paleto side. And if I want to have a more aesthetic finish, we use the chamfer preparation. Okay, so this is now my step-by-step demo. Okay, I'll quickly just go through these 10 steps, and then I'll repeat it again when I'm doing. Okay, so the number one, actually we use the depth cutter, and this one I use has got a 2 millimeter cutting depth. So we use it for the occlusal reduction. Okay, and the next one is the occlusal reduction for overall. So after we cut the depth, you need to remove the side, okay, to make it level. So I use a cylindrical burr, a short one, and then actually from the groove that we make from the depth cutter, we can actually reduce it between. Again, actually with the microscope later on, you see a lot better, okay? Number three, I will actually reduce the interproximal, okay? So there are two types of margin you can finish. Sometimes you more or less keep the contact point, all right? So you actually don't cut away and you don't have like a totally free contact. The problem is that from what I can see, a lot of times actually patients have interproximal caries, okay? So by the time you cut to the contact point area, you might see some white spot or even brown spot. In that case, you need to go down a bit deeper and remove that decay area. So most of the time, my onlay, so I found that actually I cannot just do like a onlay with the contact point. But of course, I mean, if there's no decay, you don't want to cut that away, okay? So I'll use the interproximal burr. It's my favorite burr. You can see the shape is not like just a taper burr, and it's slightly flare in the neck area. So it's for interproximal reduction. And then I use the funny shape occlusal reduction burr so that actually we create like a smooth surface on the occlusion. Okay, so there's an area we call the transition zone. Basically, it's around the four corners, the mesial buccal, the mesiolingual, the distolingual, and distal buccal. The four corners where we want to actually create like a smooth transition area. So we normally actually use like a long frame, I call it long frame polishing cutting burr. We use that. Okay, and you can see the screen is not very big, but you can see actually later on as well. And after that, I prepare my margin. So I use like a 45-degree but small diameter chamfer burr for that. And you can use that margin preparation burr more or less all around. So the step number 7, I should say. Step number 7 is the shoulder. So this is kind of optional. If you don't want to use the shoulder, you don't have to do this. But if you want to actually have even better aesthetics, and sometimes you can hide the margin completely, then I will use the shoulder. Of course, if you do a shoulder preparation, you remove a bit more of the swift substance as well. Okay? And if you don't do shoulder, you might want to do a chamfer margin, okay? A light chamfer margin, you can use the first margin preparation burr, or you can use this one, I call it the nipple burr. It's from Comet, and it has like a little small guiding tip. So it's a long cutting guiding tip at the top, and then it can actually give you the light chamfer as you run along, and I'll show you again when I do the demo, okay? And sometimes if you have a box, and you want to make sure it's a flat surface. So you want to use an end cutting burr because you don't want to touch the interproximal area on the tooth behind it or in front of it. So you use an end cutting burr just to make sure in the proximal box area you have a flat surface, because this is actually to help the onlay to sit more securely, okay, and to even out the loading, especially in the box area. Okay, and after that, then you want to finish it to make sure the whole of the preparation is smooth. So you start off with the occlusal polishing. So I have one burr like this one. It's more or less like a big round end burr. So you can see actually where I use it. But sometimes I also use this yellow football. Of course, it's like a rugby ball, like American football, okay? So we call it yellow football. And actually that you can actually help in some specific area. I'll show you where it is, okay? And sometimes I use it even just a little bit on the palatal margin as well, okay? So if you do exactly what I said, this is the kind of preparation you should expect to have every time, okay? So you should have like a smooth occlusal surface. We follow the anatomy of the tooth and with all the occlusal groove and the cuspal groove as well. And this one on, you can see I finished with like a light shoulder on the buccal side, okay? And then of course, the lab will have to make that, and this is the ornate they make for that, okay? So give them time, they can even do detailing, I mean like occlusal stain and things to make it look nice, okay? And then this is after cementation, so we use 2 types of cement, Verling aesthetics, okay? You must use a dual kill cement. Dual kill means, DC means dual kill, right? And because you need to set underneath, right? If you use a light kill cement, if your ornate is very thick and there's sometimes you may not set it completely. If it's unset cement, the problem is that you might get sensitivity, okay? And, but if you actually do it properly, and you can see, you cannot really see the margin. This is the reason why we do the shoulder preparation, right? So you can hide the buccal margin more or less completely, okay? So now, thank you very much. This is our annual presentation. We start the hands-on. So join us, okay? And if you want to learn more, we can have regular workshops. But if you have one of the vouchers, the brochures, you can actually see the upcoming courses as well. Okay? Right.
check 緊你咩？
Yeah, I can. Okay. Oh, and we'll go back to presentation. Okay. Okay, this is the step 1. Then we're going to do the depth cut. Stop. Change. Pericope. Okay, there we go. Okay, so you can see actually that we've done the first part. Okay, so the occlusal reduction is actually like this, okay? And you can use a parallel probe and you can measure and see if you have sufficient reduction. So the reduction should be actually at 2 millimeters, okay? Okay, and if it's not enough, then of course we can go back and do a bit more. You can also use this burr because, like I said, the cutting tip is like 2 millimeters, you can see. 2 millimeters. Okay, so basically, if you put it back into the box, no, not yet. Look at you. Then you can see actually which area you have not reached 2 millimeters. Then you cut again. Okay. So I will also try to extend a little bit more close to the margin. Of course, you don't want to cut it with this burr to the margin, but you want to get it as close as possible. And that will help you later on. You can also cut into the other groove area. So this is like the lingual groove. So for the area, you don't need to have 2 millimeters. You like the non-functional cup, you want just 1.5 millimeter. Then you can just cut 1.5. You can actually, like I said, measure that and you see if you have enough, okay? So for the buckle side, you can also do the same. So, okay, so you can also cut it like this. Okay, and the next step, okay, step 2, we're going to do the occlusal reduction. Okay, so this time actually you hold the burr sideways. Can you see like this? Okay, so, okay. So you follow, or the tip of the burr should be more or less touching the floor of the cavity that you cut earlier. Okay, so it doesn't have to be very, very smooth. Okay. Okay, and next step. Okay, I will cut the interproximal area. So we use this. Okay, so you have to be careful. Can you see this? Okay. On. Stop. Okay. And the next step, we do the occlusal reduction to make it smooth. Go. So you can see the horizontal groove. So we can see the groove that you had before, and you can use this spur here. To use it to smooth down the groove in between. Okay. So you can see actually it's not easy to cut this area, like here. So this is why we use the other burr we call to clear the transition zone. Okay, go.
好平嘅黑面嗰啲我都算㗎啦，發脾氣咧。
個拋大嗰啲。Okay, and the next one, the margin preparation. Okay, and the next step, this one actually we're going to prepare like a quick shoulder, just to show you. So what we do is actually we will run it actually, okay, like this, and more or less parallel to the axial wall. Okay. So the next one actually I want to show you is the lip over. Okay, it's just to show you how you use it. So basically you more or less run it along the margin. Okay, with the guiding tip just like touching the enamel. And then you can use it to cut like a very smooth chamfer like this. Okay. And next, if you have a proximal box, then you should be using your end cutting burr. Okay. So basically, you're actually running it more or less perpendicular to the margin. And the long cutting burr means that you should not be touching the one behind it or the one in front of it. Okay, so next, actually, if you want to, you can always go back to use your chamfer margin burr just to tidy up the area where you think actually the margin is not quite good enough. So you can see this is how it should look like. Okay, it's not clear. It's sharp. So, okay, but if it's area, for example, here, I want to sharpen the margin a little bit, then you can use go back to the margin preparation burr. Okay. So now is the time for finishing. So you have two finishing burr. This one with the big round head is actually to smooth down the occlusal. And you can see how we follow the occlusal anatomy. Okay. Okay, but the area actually sometimes you need to pay a bit attention is actually where you have the box and coming onto the occlusal fold. So this area, you can't use the big round head to do that. So this area, especially when you have a very deep box, then you need to use the last finishing burr, which is the yellow football. Okay, so here. Okay, so you want to use the yellow football, and you can do this, and the missile, and this one. And sometimes, if I want to have like a light chamfer on the palate, on the lingual side, then we use this. And I cut the box margin like this. Sorry, the front margin like this. Okay, and you make sure the top part here is smooth as well. White stone. Okay, so if you want to polish your prep even more, you can actually use something like a white stone, like this, okay, with plenty of water. I'm not using it here because there's no water, okay? With plenty of water, and then you can actually polish your burr even more, and to make it really smooth, okay? So this is it, okay? So this is a very quick demonstration on how we do the preparation for an onlay, okay? So if you actually look at it from different angle, okay, so with the model without water, it's not so easy to make it very smooth. But if you're using actually your friction burr, doing a preparation with underwater, then it will look a lot better. Okay, so thank you very much. Thank you for your demo. Okay, live.
過咗時間。
嚇？搞一次。
係。好。你做 model？
我哋幫我洗洗個 retractor 先啊嘛。
得。好啦，咁今日咧就會做一個 DSD 影相嘅 demo。咁個 demo 咧，我哋會影2張相。咁咧影相嗰陣時咧，我哋就會用個病人咧係頂住個位置咧，我哋要 fix 咗頭個位置咧，因為2張相我哋要重疊嘅，咁2張相咧要唔喐。跟住咧第一張相咧，我哋要影個 retraction 嘅。可唔可以用個 screen？ 好，有啲 OK。咁咧係啦，咁個病人咧就會，我哋今日個病人好專業啦，咁佢會 set 自己 retract， 係第一張 retraction。跟住咧佢要唔喐之後咧，就拎走2個 retractor， 再影多一張。通常我哋會試好多次，再嚟多次啦，再 retract。係啊。跟住係啦，另外一張就拎咗 retractor 啦。咁咧，當個病人試驗咗幾次之後咧，我哋咧就可以影相啦。你等等啊。係啦，第一張咧，咁我哋通常都會 fix 咗個相機啦。fix 咗個相機嘅話咧，個角度就唔會喐。第一張。跟住另外一張就可以拎咗 retractor， 唔得啦，佢喐咗啦，再嚟過，係啦，呢2張相咧要個頭係完全 fix 咗同一個位置。OK， 第一張 ，OK， 第二張，係啦，呢個病人開始專業咗啦。咁我影咗2張相咧，呢2張相咧就可以愛嚟做我哋嘅 DSD。係啦，你會見到呢一張相咧就係 retraction。OK 嘅，唔該晒。另外一張相咧就係冇 retraction 嘅。咁咧，我呢2張相嚟做咩咧？就係我嚟做 DSD 個影相。咁今日就係想同大家講一講 DSD 影相個模式，同埋 DSD 我哋做啲咩啦。咁 Digital Smart Design 咧，其實我哋要影2張相。頭先我哋有 model 喺度啦 ，photo 示範咗啦。一張相咧，你會見到咧係 retraction， 另外一張相咧就係冇 retraction， 而個病人笑住嘅。咁2張相個重點咧，第一要2張相可以重疊啦。第二個重點咧就係咧，你會見到咧2張相咧，我哋都會見到2隻耳仔，即係話咧我哋會見到病人個中間線。咁我哋冇示範咧，第3張相咧就係 12 o'clock view 咧，就要病人烏低少少影嘅。咁從而咧，我哋就可以有做呢個 Digital Smart Design 啦。咁點解我哋要做 Digital Smart Design 咧？因為咧，大家都試過咧，我哋印咗個牙模俾工廠，跟住咧就究竟我哋點樣將牙模裡面嘅 information midline、occlusal plane 同 smile design 俾我哋工場做 raise up 咧？咁相信大家都試過咧，我哋就咁印咗個牙帽，就張 lab 紙就同個工場講：麻煩你幫我做13去到23個 raise up。咁但係工場其實冇資料嘅話咧，其實佢幫唔到你做嘅，因為所有資料咧應該係我哋俾個工場。咁所以咧呢個衍生咧就係 Digital Smile Design， 就係一個巴西好出名嘅 technician 兼牙醫 Christian Coleman。咁因為佢發現咧原來個牙醫之間係唔夠溝通，所以佢決定咧就用一張 clinical photo 就嚟做一個溝通。咁就係將3條線畫3條線咧，就擺最初期嘅 Digital Smile Design 咧係畫3條線嘅啫。咁後期嘅 Digital Smile Design 咧，我哋會有個 template。去到而家嘅 Smile Design 咧，已經我哋會用 facial scan， 用好多 software 幫手。但我始終都會覺得咧，以前嘅 Smile Design 咧，其實係幫到好多手嘅。咁點解要幫到手咧？因為咧，如果我哋就咁印個帽俾工場，叫佢做 raise up 嘅話咧，工場冇任何資料咧，其實佢做唔到嘅。就好似一個Blind Man and Elephant 啦，每個人摸嘅位置唔同咧，其實都估唔到嘅。咁咧頭先呢個病人咧就10年前咧，我就用呢個 case 咧，我做一個 Smile Design 啦。佢個投訴咧就係話佢 anterior spacing。咁咧佢就冇咗2隻 lateral incisors。咁呢個中間線咧就未有少少。佢以前做過 ortho， 但係就冇戴個牙箍咧，就 relapse 咗。咁我哋睇個 X-ray 咧，見到咧就冇2隻 lateral 啦，咁2隻 canine 挑咗埋去。咁病人咧就想做一個 smile makeover。咁有唔同 treatment plan 啦，當然我哋可以將嗰個 ortho 將嗰個位置打開咗，落2支 implant。咁但係我哋會考慮到 implant 會有 implant 嘅問題。或者我哋可以做 orthodontic， 將個位置擺翻靚少少，做幾隻 veneer。呢個嚟得咧時間會短啲。咁其實呢個病人咧就拒絕咗 ortho， 亦都咧好希望咧1個月後咧可以做咗 smile makeover， 因為佢嗰陣時咧佢1個月後咧要上無線電視做一個節目。咁我哋知道咧，facial treatment plan 咧，其實我哋所有 treatment plan 咧，其實就應該要影個相啦。而影完相之後咧，我哋就 design 翻唔同個 step。咁遲啲你上個堂，我就會慢慢辜負翻。咁我講過啦，2015年個 Digital Smile Design 咧，其實我哋會個 template。咁同埋咧，我哋需要錄個 video， 因為 video 咧個病人先會放鬆少少。講嘢，我哋會有埋個 lip movement， 會多咗好多資料。咁頭先 Water 示範咗啦，我哋影咗2張相啦，一張 retraction view， 一張係 smile view。咁咧，我哋就第一個 step 咧，就將張相咧擺翻落去個 template 裡面。個 template 咧，其實咧，我哋就可以將張相慢慢調控翻，調校翻一個我哋覺得最理想嘅位置。因為咧，如果大家知道咧，其實係冇 facial midline， 因為其實每個人個塊面係唔對稱嘅。咁 step 1咗之後咧，我哋 step 2咯。step 2咧就將頭先一個 smile view 咧擺翻落去，因為2張相係重疊嘅話咧，我哋可以將2個 image overlap 咗。overlap 咗之後咧，我哋就有晒所有資料啦。個 facial midline 喺邊，而個 smile curve 喺邊，我哋就可以用咗呢個資料咧，就做個 smile design。咁跟住咧，我哋可以 zoom in 咗之後咧，我 determine 到一個 smile curve，insert S 之後咧，我哋就可以將嗰個 proportion 嘅 ruler 擺落去。呢個 ruler 咧就可以俾我哋做一個 smile design 啦。咁跟住咧，我哋就可以將個 superimpose 翻個 retraction view 落去。之後咧有齊所有 information 咧，我哋就可以做個 smile design。咁你會見到咧呢張相個 mon 有少少問題啦。咁其實呢張相我哋會見到咧，如果我哋希望做一個 veneer 係 match 個 facial midline 嘅話咧，我哋會需要磨好多牙先做得到。咁透過呢個 DSD 咧，我哋同病人解釋翻咧，其實如果我哋將個 facial midline 轉過少少嘅話，個 midline 轉過少少2mm 嘅話咧，我哋幾乎唔需要磨牙。咁大家都知道咧，其實 Cockinch 1999個 article 已經話咧，其實個 facial midline 咧，如果歪咗4mm 咧，其實個病人都見唔到嘅。但係如果 facial midline 係挑咗嘅話咧， 就會見得到所有嘢會唔啱。所以 that's why digital smart design 係開始流行，就因為我哋會多咗好多 information。咁 step 4咧，我哋就可以用個 caliper ruler 咧度咗個病人嗰個牙個闊度係8.5毫米。咁個比例咧係96%。咁我哋知道咧，其實牙齒個比例大概係75至80% 係最理想啦。我就選擇80%。咁80%我就量度翻究竟佢個牙個闊度係幾多啦？係9.5毫米。which 咧其實我哋知道咧9.5毫米咧係一個正常嘅 central incisor 個 width。central incisor width 大概係8至11啦，係個病人唔同啦。咁跟住我哋開始可以畫個 marginal ridge， 畫個 gingival margin。畫完之後咧，我哋就可以用嗰個 ruler 度翻，俾個工場就講俾工場知，我哋個 VSW 希望 lengthen 咗幾多。第5個 step 咧就打斜影張相，我哋嘅 child focal view 咧個病人會知道咧佢個門牙同埋下面嘴唇嗰個空間係幾多。咁我哋就知道究竟我哋呢個 case 咧可唔可以 additive 加出去？因為咧通常我哋希望個門牙個位置咧，其實就喺個 vermilar border of lower lip， 即係話呢個 case 咧，其實我哋可以 additive add 出去外面。咁係咪用 Facebook 咧？其實大家知道咧 ，Facebook 係會有好多錯誤啊。因為咧，當個病人個耳仔如果一高一低嘅話咧，我哋將個 ear loop 將個 Facebook 俾我哋工場做 VSW 嘅話咧，如果我哋個 ear loop 係唔啱嘅話咧，全部嘢都會歪晒。咁所以咧，其實我就唔會用 Facebook， 我會用 COIS 一個叫 Dental Facial Analysis System。咁其實咧，佢就一個 plane 啦，同埋就有個 central rock。咁我用呢個外嚟量度翻一個 reference 嘅 midline、interpupillary plane、occlusal plane 同埋 affixed plane。咁就攞到 record 之後咧，其實咧我哋就可以 transfer 咧 articulator。咁 articulator 咧就可以個工場可以做一個 VSW。咁我將呢個 case 咧，將個 DSD 結合咗呢個 Dental Facial Analysis System 咧，喺2016年 publish 喺 Compendium 同阿 John COIS。目的就係講我哋點樣可以將個 DSD 個 information 俾翻我哋個 lab。咁我哋用咗呢個 Dental Facial Analysis System 量度咗所有嘢之後咧，其實我哋就可以 record 咗個 functional and aesthetic parameter， 亦都可以掹咗落去 articulator 度。咁而個 articulator 裏面咧，其實咧喺呢個 Panadin 咧裏面咧，亦都有一個我哋叫做index tray。咁頭先 DSD 我哋知道咗嗰個牙個闊度係9.5mm 咧，我哋用咗個9.5mm 嘅 index tray 出嚟。咁咧裏面就有晒 proportion 咧，咁工場咧就可以用呢個 index tray 個 proportion 咧做個 VSW。咁有個 guideline 嘅話咧，個工場就有 proportion guide 啦，同埋有個我哋叫做 incisal plane。個工程就知道究竟 VSW 幾多，有個 guideline 喺度。咁做咗 VSW 之後咧，通常我哋都要自己 rectify 翻啦，因為咧，如果大家仲用 analog 個方法嘅話咧，好多時工場可能做 VSW 做多咗，唔係我哋指引。咁所以咧，我中意咧就用嗰個 VSW 咧，用嗰個大粒式 VSW 做一個 silicon index， 擺翻落去我嘅 study 度量度翻究竟位置啱唔啱。咁而家我哋有呢個我哋而家用 digital 嘅話咧 ，digital 嚟得簡單好多啦，因為你可以同工場溝通翻究竟 digital 嗰個位置加幾多。但係 in the old day 10年前咧，我哋冇 digital 咧，個方法就麻煩咗少少。之後大家都會知道啦，當我哋做咗 digital smart design 嘅話咧，我哋做 child smile， 因為咧我哋通常嚟講咧，我哋未車牙之前咧，會俾個 child smile 俾個病人。佢覺得滿意咗 rectify 咗之後咧，我哋就 proceed 個 treatment plan。咁同樣地咧，病人滿意咗，我哋知道咗之後咧，我哋就可以 proceed 個 treatment。個 treatment 咧，第一個咧就做 surgical stand 啦，因為我哋希望將個比例增長咗。咁所以咧就我用咗個塞單，用咗個bitching tray， 做咗個 index， 做咗個 surgical stand 咧，就做咗個用咗 laser 做一個 crowning phonic。2個月之後啦 ，stable 咗之後咧，我哋就可以 pap 牙。咁 pap 牙嘅話咧，我哋就可以擺翻我哋 index， 我哋個surgical stand 擺翻落去咧，我哋會知道咧呢個位置同埋呢個位置我要磨多少少咧，先可以將嗰兩隻 canine 扮個 lateral。咁我哋就磨牙啦。咁個 minimal pap， 因為頭先我哋 DSD 知道呢個 case 我哋 add 出去，變咗我磨牙磨好少，我淨磨0.3個 mm 個 chamfer margin 俾間 lab，個 lab 就可以做個 veneer provisional。跟住咧就可以做 perfect， 因為我本身最中意做就 perfect veneer， 因為顏色比較靚啦。咁就係一個意大利技師 Lamberto 幫我做嘅。咁你會見到好個技師做出嚟個效果咧，呢個 mon 爭啲咁多，但係你會見到個 incidental edge 有個通透度，同埋個幕科做得好靚嘅。另外一個好嘅技師咧，佢做出嚟咧，你會知道咧，呢個 case 本身隔離個，我哋將個 canline 扮個 lateral。咁佢扮得好嘅話咧，佢 distal angle 咧其實佢收窄咗嘅，收窄咗之後咧，令到喺門牙望出個視覺咧，個 lateral 嗰個 canine 就比較細隻咗，所以你會見到個做完之後 post up 嘅效果係非常之理想。咁呢個就 DSC 個好處咧，就係我哋可以撇得咗好多步驟。有乜好處咧？第一，我哋影完相，我做好多嘢咧，個病人覺得自己 involve 咗，因為佢知道到預期效果係點咧。咁同時間咧，因為我哋知道咗預期效果先車牙嘅話咧，我哋可以做到一個 minimal invasive 嘅 treatment。咁另外可以做咧，其實咧而家我哋會戴埋啲眼鏡咧，做一個眼鏡去影唔同嘅相啦。一個相就 normal smile、live in repose 或者 Duchenne smile。做影晒啲相之後咧，我哋知道 lift movement 嘅話咧，其實就可以愛嚟做 on for 做其他治療 ，which 以前咧我哋比較 ignore 嘅。咁我哋點樣做法咧？我哋影咗幾張相之後咧，同樣地咧，好似頭先咁咧，個 position 就要一模一樣。咁因為我哋有副眼鏡咧，定咗個位置咧，其實我哋 overlap 個 image。嗱，譬如 overlap 啲 image 呢個，我哋就可以知道咗究竟個 canal 嘅位置喺邊啦，同埋知道個 lift mobility 有幾多。咁你利用咗呢個資料嘅話咧，對於我哋 on-for treatment 都好有用。係啦，呢個就係 Duchenne smile 啦。我會知道個病人個 lift mobility 原來6個 mm 嘅話咧，咁我哋會知道如果我哋做 on-for 咧，究竟需唔需要磨走幾多骨？因為如果唔係咧，當個病人笑嗰陣時見到個產生鬆鬆嘅話咧，其實就係一個 disaster。咁從而咧呢個 case 咧就可以知道咗究竟我出咗個 stand 點樣做啦，磨冇幾多啦。咁呢個 case 我都 publish 咗喺 compendium。咁變咗咧，我哋知道咗啦。咁變咗我知道 bone level 係幾多咧，所以出咗街嗰陣時咧，我哋都有計劃磨牙磨走幾多，從而咧個病人做完 on-for 之後咧就唔會見到嗰個長出鬆鬆。咁可以做一個好全面嘅計劃。咁變咗咧，我哋喺 show stand 嗰陣時咧就知道有個 bone reduction 街咧可以磨牙走。係啦，咁就多謝各位。咁如果想多知詳細啲個 information 嘅話咧，就可以裝我哋 Academy 上個 full course。唔該晒。